Oh,
Is I coming? Should we wait for some time?
I'm sorry.
Is I coming?
I'm gonna check with him again. What did he say to you?
I did text him today.
Okay, try to get a hold of Mike, will you, please?
For those who have just joined, I think we are waiting for Dr. Ibe to log in.
We're waiting for Dr. Ibe.
Have you tried to call him?
Yeah, he's coming. Just a second, I gotta get him the link. Oh, I'm here. Are you here, Juma?
Yes, yes, I'm there.
Good, he's here. He's
Okay.
coming in. Pipe, are you there?
Yes, yes, John, I'm very much here. So,
Oh, good.
uh,
Okay, you ready to start? You wanna present first, right?
yeah, so I'll go ahead and present first. Um, you know, um, I'll talk about the brainstem. Juma, good
Yeah,
to see
hold
you
on,
around.
hold on. Let me start and then you can talk, okay?
Yes.
You know, ready to start? Juma, say hello to Ike.
Hello, Dr. Aib. How are you? Good to see
Yay,
you.
Juma. Good to see you, Juma. Very good to see you. How are you
Okay.
It's
doing?
been long. I'm fine and
Your
great.
background is crooked. It's crooked.
I'm
Your
in the
background is tilted.
I'm in I'm in Jaipur for the World Neurotrauma Congress tomorrow. We are doing the world's first exoscope anatomy workshop in neurotrauma.
There's a saying in sports, don't play the game in the locker room. Well,
Mm,
let's get on the field first, and then you can
Yeah,
talk
sure.
all about the events and the world events and everything else. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett broadcasting from beautiful Miami Beach, all the way to Jaipur, India, and to Tanzania in Africa. Today we have the Tanzania Grand Rounds for challenging skull base and neurovascular cases, headed by Ip Cherian, well-known educator from India. And Ip is in Jaipur, India, where things are going on. Ip, tell us all about it.
Thank you, John. So we are in this lovely city, the pink city of India, Jaipur, and India is hosting its first World Neurotrauma meeting, ICRAN. And we have our entire team from all over the world here. And tomorrow we'll be having a live workshop on cisternal opening, how to open cisterns in trauma using microneurosurgical approach, which we call as cystonostomy. So tomorrow there will be a live workshop, and that will be a 3D exoscope workshop, probably first in the world, using both the Sanma exoscope and EOS Esculap exoscope. So tomorrow there will be a live feed. We will hand over the YouTube link to John. And
Oh, great. We'll be able
today,
to televise it then, right?
yes,
Oh,
yes, yes,
that's
that's what.
great.
So we will hand over the neurotrauma meeting, like in the Africa Big Five. This is one of the Big Five meetings in the world. So it is attended by huge number of neurosurgeons, and I am very honored and I'm very thankful to lead this workshop, and especially on our technique of sonostomy. And we will go ahead and demonstrate this to over 60 participants there and to many thousands of participants on the net. So I'll go ahead and share my screen right now, and then we will show you a brainstem. So 3 days before we had done a brainstem tumor. It was a 21-year-old boy. The tumor, unlike anything that I have seen in the past 15 years, was completely firm and was like a meningioma, and it was inside the brainstem. So we really didn't have a plane, and we had to rely completely on the SSCPs, MEPs, and we were doing this every once we removed enough tumor, we were doing this every single minute and then trying to see whether we are hurting anything. So once we had irritation of the 12th and motor tracks, then we had to stop it. The boy is doing fantastic. He's got some posterior column issues, but the power is remained the same. And we hope that he'll be completely okay. So we are hoping and praying that he'll be completely okay. So all these cases, I don't have the video because the next day of operating, I had to come to Jaipur, so I don't have his video. I'll show it on another day. But today, I'll show you a dorsal exophytic brainstem tumor, which we have done a couple of years back, and I'll go ahead and show this video. So, and I'll clearly show you. I mean, we have a large experience with brainstem tumors. I tend to operate most of them. So I'll go ahead and show you. First, I'll share the screen. Can you see my screen?
Yes,
All right. So
perfect.
We're starting now. This is a brainstem tumor. Why I want to show this to African grand rounds is that I must let them know that these are tumors, not they are not inoperable. You see this tumor, okay?
mm,
one look, you may think it is inoperable and there is nothing that can be done, but it's not true. So it's you can take it out. Okay, this is a pilocytic astro, and this boy is doing a job back in his home. So this is exactly what I want to show. Uh, and I have operated here with just seventh, ninth, 10th stimulations. And yeah, so you can see how the tumor is now. It's in the medulla and the pons. So you can see the tumor now. It's nicely dorsally exophytic, but you can see the part of the pons it's affecting, and the medulla, you see, there is nothing left here. See, it is really into the medulla. It's burrowing into the medulla. Okay. So if you
Yes.
see here, we are opening.
So what was the approach, if I may add? Sorry for interruption.
Yeah, so it's a very simple posterior midline approach, and you can see that's the midline. That's the midline, and we have
Okay.
taken off the C1 arch and a small craniotomy, about 3 to 3.5 centimeter craniotomy, exposing the midline and the cervicomedullary junction. That is all the approach is. So we cut uh, a dura like this, with the occipital sinus is ligated, taken up, and after that we cut it towards the cervical spine. So you can see now the tumor is seen here under the tonsils. It's almost the same yesterday's tumor also, but very, very hard tumor. So this, all the supplies to this tumor, we have to look for the supply. And if we are completely sure this is the supply and not a traversing vessel, we can go ahead and take the supply off, so that this tumor becomes a little bit um, less vascular. It's much better that way, because if you have a bleeding tumor while you are taking out with CUSA, this poses a problem for control and how comfortable you are. So you go ahead and keep on taking this. On the tumor, cyst, whatever vessels are there, you can take it off and start decompressing the tumor. Using a suction and sometimes a CUSA. So using the bipolar in my left hand, and using the suction and the CUSA to identify any plane that I can. Keep on decompressing. Now, what we are seeing is the tumor invading the medulla. So we have to go and take out this pia onto the other side of the medulla. And you can see that the tumor is here. So you have to remove that tumor. This is a heartbreaking job. See, the tumor is completely different consistency. You can see that. So unlike the tumor that we did day before yesterday, this is and it's a completely different consistency. And this is very good for us, because we can take it out. And whatever brainstems I've seen, most of them, although they are very tough, they are different consistency. This is how you can go ahead and differentiate it from the brainstem. But sometimes you get difficult tumors like yesterday. And although I don't want it very often, it was a different experience. So we are removing tumor to tumor plane we are creating. You should never create a plane which is tumor to brainstem. This is a mistake. So when you do that, when you create a plane tumor to brainstem, then it's a problem. So you always have to take tumor to tumor. So we are going to we are going ahead and seeing how much all the anatomy we are identifying, or bags we have to identify. Keep on removing the tumor using CUSA. See, now you can see the brainstem coming, and the brainstem is completely down. I mean, I hope you can see it in 3D. See, the brainstem is so thin here. Can you see? There is a very thin brainstem. So I'm not getting hemostasis there, and that's brainstem there. That's obex here, and after the obex, this is the brainstem. The tumor has been completely removed, taken out. On this side also taken out. That's the brainstem, anterior part of the brainstem. So I'm demonstrating how thin the brainstem is. So very gently hold the brainstem, see whether you are able to identify the denticulate ligaments and cranial nerves 11. Very gently look at the sides. So that's the brainstem. And if you damage this, then this patient will be in a pretty bad shape. So here we've been able to remove a gross totally. And you see, this is the part where the brainstem is completely going down. This is where the tumor was. This part was where the tumor was. Now we go to the top of the fourth ventricle and remove whatever tumor is in the superior medullary velum. So there is some tumor attached to that. So that is also removed, and that's all cleared. So you can see the post-op scans. This patient when walking from home, so you can see how thin the brainstem is, literally nothing there. So it's come back, and so I uh, I I would rather ask, I mean, if anybody has any questions. So yesterday, I mean, day before yesterday, we did this tumor with the exoscope. I don't think anybody in the world would have done a brainstem tumor of this sort with an exoscope. So yesterday we did it with an exoscope, and tomorrow we have both the EOS and SANMA exoscope, SANMA Yoko, tomorrow at the World Neurotrauma meeting. People are feeling it out how the exoscope is very different from the microscope, the increased magnification and how beautifully you can maneuver it and the ergonomics. So I was just telling my team that we would be the harbingers of change. We are not going to do anything like what has been done before. We would be dedicated to changing things for the positive and the better way. So yeah, paradigm shifts everywhere. We've done that with cystonostomy. We've done that with the skull base approaches. We've done that with exoscope, AI, robotics, and we will keep on following that. Now, here we have a team from all over the world, and it's amazing to see all of them. So we have Professor Ramdas, we have Nargiza from Uzbekistan, Afsal from Germany, we have Mario from Oxford, and Fazal and Lukman from Indonesia. So all these, I mean, Sugar from Peru, all these guys are there. They are experts in cystonostomy, so tomorrow they'll all help us to lead the workshop. Now, if there's anybody has a question for this case that I've shown, I'll be happy to explain. Otherwise, I'm a bit down on the. I mean, I'm a bit. I'm having a small running nose, and I've been traveling continuously. I guess I need some rest, so I'd rather take some rest. And I'm sorry I was a bit late here. So if anybody has a question, I'll be more than happy to answer.
Yeah, I'm happy to start, Dr. Ibe.
Yeah.
Congratulations for the, for the good dissection and good tumor removal, excellent surgery, I may say. Thanks to the exoscope, the magnification is so nice. Even the image is so clear. My question will be on the, does the exoscope allow you to inject a contrast to see that you have removed the tumor completely? The endomethane, I think.
Yeah, so the exoscope has both the blue filter and infrared filter. So you can either use ALA,
Okay.
sodium fluorescein, or ICG. The exoscope, AOS exoscope has that, and the Sanma exoscope has the ICG filter. So it doesn't have the blue filter, but it's and I think the new one, the second prototype, will have the blue filter as well.
Okay. Okay. Wow. The exoscope has, the advancement in the technology has led us to say the inoperable tumors become operable tumors now. I think this is what I see
Absolutely,
now. In our
absolutely.
setup, to be honest, in our system would be like, we are not going to operate.
Mm.
Yeah.
The whole message of this Tanzanian Grand Rounds is that when I have been coming to Africa, what I've been telling people is that you should go ahead. There is no point of you stopping anywhere. You have to go ahead and you have to keep pushing the horizons forward and forward and forward. And I see a lot of guys sending me cases from Africa, which they've done. I'm very proud of them, very, very proud of them. And I'm sure very soon Africa will be doing, there is no lack of skills with you guys. So it's just the technology and it's some small problems. You sort it
Mm.
out and you will do, you will be teachers very soon. I mean, this is what I hope and I dream that I see people from Africa coming and teaching us, coming and teaching the West as to how these tumors are operated in their way, in with good infrastructure, with good everything. So this is my dream, and I hope very soon I can see this happening.
We will be lucky, we'll be humbled to be trained by you, and we are looking forward actually to come June or July. We may come there at least for a month to
Yes,
learn how to do cystectomy in your lab, in your hospital.
yes, yes. You're very welcome, Juma. Very welcome.
Dr. Salim is here also, is very interested in some of the skull-based techniques. So, Dr. Salim, do you have any question? Some people were here, I think they left because they thought it's 4:30, now it's going to be maybe 5:30.
Yeah, I understand. I understand.
Do you have a question, Dr. Salim? Dr. Salim is a resident, a senior resident in Mumbiri,
Yes, yes.
neurosurgery.
Yes, some of them was very good. There was one chap who sent me a case and they had operated and they had done a fantastic job. He was, I think he was a junior neurosurgeon. So Max, I think.
Yeah, Max, yeah. Actually, because of the clinic today, Max was going to present a case of a brainstem tumor that needs your opinion, but
Yes,
he's
yes.
stuck in the clinic.
No problem, no problem.
Great, great.
So it's completely okay. So what I'll do is I'll sign off now, and if there is anything, John can call me. I'll take some
We
rest.
we just have a
Maybe.
quick we just have a quick case I can share, just
Yeah.
opinion.
Yeah,
Yes,
okay.
It
please.
was a case of a petroclivo meningioma. Can I share, Dr. John?
Sure.
Yes, yes, please.
Yeah. So this is the mother who was attending clinic. I didn't operate this woman. She's a 47-year-old woman. Can you see my screen now?
Yeah, make
Yes.
it bigger, Juma. Make it
Okay, now it's there.
present. Yeah, perfect, perfect.
So she presented with ataxia and blurred vision and left-sided hemiparesis. And I think the seniors who were there in 2018, they operated. I think it's a far lateral approach.
Hmm.
So she was operated, but the I think they left some tumors because the petroclival meningioma, the location, they are deep, and the instrument that we have, what we are talking on now, we have limited of resources sometimes, the queues and the stuff. So they left some tumor. Currently, the patient is attending our OPD, so she's still ambulant. She's ambulant, but it's limping with the limping gait, dragging her left side. But the rest of the symptoms improved. The tumor, which is still there, as you can see in this image, and I have the further images also. You can see the tumor is left here and is still growing.
You
So we
know,
want
I would like to point out to you one important thing. Can you see the edema of the brain stem in the flare images?
okay.
Can you see this?
This
Can you
one
see?
here.
Yes,
Yeah,
the
yes, this
edema,
one.
the edema. Can you
Yeah,
see the
here.
edema? Yeah, this is very significant in a petroclival meningioma. So in this case, it is best to, from our
Okay.
experience, when there is edema like this, massive edema like this, you should go for, instead of trying to pull out this tumor after this little bit of decompression, you should go for a complete intratumoral decompression with the help of intraop CT, and
Okay.
as much as you can, and just leave the rest of the capsule, maybe one few millimeters of capsule, just leave it. Because if you try to pull it out, there can be vasospasm or damage to the perforators, and this will be disastrous. So in this,
Okay.
this is a case where I would also probably just decompress.
So this was 2018, and this was the post-op here on the right side, you can see.
Yeah,
And I can share the current images now.
yeah,
So but it's not different from the post-op because the tumor was still there, and we were wondering, the tumor is still invading the cavernous sinus.
yeah,
With this tumor, with the histology result that we have a meningothelial meningioma WHO grade 1,
yeah,
and with the thinking that this tumor is deep located in the skull base,
yeah,
should we redo surgery
yeah. So
or
redo
go for
surgery, go
more
into the
radiation?
tumor. I would I would go into the tumor,
Okay.
decompress as much as safely within the tumor, as much as possible safely within the tumor. You leave the capsule, and then about
Okay.
6 weeks later, you see if the tumor is reducing in volume, and then you can send it for radiotherapy. But this kind of this bigger tumor, if you do radiotherapy, this is not good. So
Okay.
I would go ahead with as much decompression, maybe go from a small subtemporal approach, peel
Okay.
off the peel off the temporal lobe away, and then do a
Okay.
Kawase. Then from there,
Okay.
do as much decompression as possible,
Okay.
whatever is possible by you without really pulling anything. And
Okay.
and then the capsule can be left without really pulling it off the brainstem. If it is coming out, fantastic, but otherwise, no. And once you decompress that, you wait for about 6 weeks, and you see how the tumor collapses. And then you can plan on your radiotherapy, either yes or not. And chemotherapy doesn't have any role.
Okay. Okay. Because it's a grade 1, so we were
Let's
wondering if
show
radio.
Nanu Nani how we do Chandapu.
Yeah.
Whoop.
Thank you for the opinion. I think that's I will suggest this to the seniors, okay, and we can do together maybe with some of the colleagues here.
Yes, please. So try to do a small subtemporal approach. Try to take out
Kawase.
the Kawase approach. So try to take out the temporal lobe. Try to drill as much as Peter's bone as possible. This will take off its vascularity.
Okay.
Cut the tent after clipping off the superior or bipolaring of the superior petrosal sinus. Cut the tent, and then you will
Okay.
find that the fifth nerve is completely elevated, and you, from the fifth to the seventh, in that window, you can start decompressing this tumor beautifully. And
Okay.
you see, if it is too hard, you have to use bipolar and tissue, maybe like a pituitary punch or a disc forceps. And
Okay.
without really pulling or pushing, you just steady it with the suction and keep on cutting it off as much as you can. And
Okay.
once you finish as much decompression, you're seeing the capsule, then you can leave it and then come out.
Perfect. Perfect.
It's very safe.
Okay. Thank you so much. I think that's wonderful. Okay, we will do it.
Yeah, sure. Okay then.
Okay,
Yeah.
then. Thank you so much.
Okay,
Yeah, see
are
you
you gonna
guys.
present, Juma? Are you, what's gonna happen now?
No, that was the case that I wanted to present, and Max had a case of a brainstem that he wanted, knowing that IPE is going to present on brainstem. He had a case of a brainstem lesion, which is not yet operated. So I think because of the clinic, maybe next time, the next 2 weeks, maybe he can present it and we can get opinion from Dr. Aip.
Yeah.
Yeah.
Do you have something
About
today?
timing-
You have
about
something today,
timing,
right, Juma? Yeah, you have a case today. Do you have another
The one
case?
that I presented is the case.
Oh,
That
okay,
was the
that's
case
it.
of Dr.
Okay,
Joma.
okay. So,
And about timing, do you think we can move it to 5 p.m.? What is your opinion?
Yeah,
Just
sure.
want Dr. Aip's opinion, because that time will be very late in India.
No,
5
no
p.m.
problem.
our time, but
5
yours will
p.m.
be
would be 8:30. 8:30 in India.
no, it's 2.5 hours. So it will
Yeah, so it's
7:30.
yeah, that'll be absolutely all right. No problem at all.
Okay.
okay, now when is this? You guys have something planned? Let me know. When
Okay.
is
Yeah,
it?
sure.
When do you
Sure.
want to
So
do it?
this is going to be on the 10th of March.
Okay,
Yeah,
so
sure.
coming up. Okay, we can plan
Yeah.
that later.
Yeah.
Okay, are we all set here then,
Yeah, sure. Guys, I see
Okay,
Othman and Harshad also, say my regards to them. Lemery also is here.
Actually,
So,
Othman was here. He chipped in, but he
and
just left.
Lemery, I see
And
him.
maybe he will
And
come
Harsh,
because this is his case. The one I presented is his case.
I see.
So I think he will
And
join.
Harshad also, I see him. So
Okay.
my best regards to all of you. God bless. See you
Okay.
guys.
thanks,
See you.
Okay, let me just explain to Ike, but basically now we're having vendors show their products. We're not necessarily approving or not approving, but we give the vendors like Ram Kumar is going to give a presentation now after the didactic presentation, and we welcome Ram, and he'll be showing, I believe, a short video, and then have a couple take questions from the audience, which is innovative. Okay, Graham, how you doing?
Yeah, hi. Hi, good evening, Doctor.
Ram, I am in
I
Jaipur.
can see
I
you
believe,
feel very tired, Doctor.
yeah, I believe you are also in Jaipur, right?
Yes, Doctor. Yes, Doctor.
Yeah, so you carry on with it. Let them ask questions to you. Tomorrow I'll be demonstrating with your exoscope and the AOS exoscope. We are very
Okay,
proud
Doctor.
of how you have evolved with an exoscope. So I believe it would be the future. So go ahead and please present to them. And
Thank you, Doctor. Thank you, Doctor.
I'll carry on. I'll
Thanks,
just
Ike.
get some
Thank you,
sleep.
Ike.
Yeah.
Please, Doctor. Please. Thank you, Doctor.
See
Thank
you.
you. See you, Doctor.
See
See you
you.
guys. See you. See you.
Thank you. Bye-bye.
Okay, Ram, can you carry on?
Yeah. Just a minute. Just a minute.
Okay. This is kind of a new thing we're incorporating into the webcast because medical device companies and pharma has always been part of neurosurgery education, of all parts of education. And we want to welcome them to this platform to explain the device they have. I know neurosurgeons have questions about some devices, and certainly one of the devices that Sandmar features is a low-cost operative by microscope, which all countries want to hear about. So anytime you're ready.
Yeah,
Shuma.
here we go.
Okay.
Can you
Yes,
view my
perfect,
screen?
perfect, perfect.
Hi, Dr. Megago, how are you?
I'm fine. How are you, Ram?
I'm doing fine, well, sir. I think Miss Chessie is in Chennai. Tomorrow she is coming to Chennai.
Okay.
Yeah. So we will be having some training session instructions in Chennai, India, for the next 2 days.
Okay.
Yeah. So this is our neurosurgical operating microscope. It is a brief, a few slides about the microscope. Before that, what we make, Sanma makes is the surgical operating microscope, 3D exoscope, and robotic assisted endoscopic arm. So as
Okay.
of now, there is robotic assisted arm might be it's under a regulatory process. Very soon, we are going to come with the launching program. So as of now, this one, the surgical operating microscope and 3D exoscopes. So we manufacture and it is in the market, and we are expelling with a lot of features based on the feedbacks. So Sanma Surgical Operating Microscope is the only Asian and third global brand making microscopes for all microsurgical procedures and diagnosing applications. So like neuro, spine, ophthalmology, ENT, plastic surgery, urology, and colposcope, and dental. And again, the only Asian and fourth global brand making microscopes for neurospine and plastic surgery specialties. So the other is Zeiss, Leica, and Mitaka, and we are the fourth brand making a microscope for neuro applications and spine applications. So these are the basic features of our optics and illumination and ergonomics features. And this is our neurosurgical operating microscope, the image. So we offer a binocular tilting range from 0 to 210-degree tiltable with 10x eyepiece. And the advantage, our other thing what we offer is that integrated inclined angulation eyepiece extender, so that it ensures the surgeon's next train where he is about to perform the surgery for more than 5 hours or 10 hours or whatever they say. So that is a specialty of our microscopes. And the other thing is like we give optional as diopter adjustments, +6 or -6 or -8 or +5. And magnification control, we give zoom with a type of 1:6 ratio, which comes to 24x zoom. And working distance, we give continuous variable working distance from 200 to 500 mm. And we give the illumination light source like LED, the daylight bright temperature, which is equal to xenon. Why we are not giving xenon is that xenon bulb life is only 500 hours. This LED minimum, it gives 50,000 lifetime of the bulb performance, and equal to the xenon light source color temperature. So that's why we chose this LED light source instead of xenon. So that is a main advantage of the Sanma surgical microscope for neuro applications. And we offer a 6-axis electromagnetic brake system, joystick powered for optical head movements, for fine movements. So this feature only in other competitive brands, they offer in high-end microscope, which is expensive, more than $1.5 lakh. So we give in our basic range itself this joystick controls for the optical heads fine movements. And simultaneously, we offer a multifunctional hand grip controls for the zoom, focus, illumination, and even camera controls, ICG controls, everything. And the same controls we offer as optional with the foot switch controls also, including this XY movements. And this is what I said, the 30-degree inclined angulated binocular tube extender. So this gives that instead of just going forward, so you can just stay for as it is a comfortable position, you can perform the surgeries. there is advantages where we are included in this microscope. And this is that side co-observative or face-to-face. And this is for the spine or plastic surgery exclusively for a lateral view. And this is that joystick control and foot switch controls for zoom, illumination, focus, and 6S electromagnetic brake systems, and joystick controls also. We offer these filters, ICG filters, yellow 560 or IR 800 as optional. And 400 is under regulatory systems. So as of now, we offer 560 and 800 filters. And for imaging system, we offer full HD or 4K with the live video recording and still image storage of capacity either 1 TB or 4 TB terabytes as an optional internal storage capacity. And simultaneously, through USB, we can store the live surgeries or still images in external memory also. And these are the connecting like a 3G, SD, HDI, DVD, and we give this high range bandwidth of cable connectors. So the signals, video signals, it gives perfect transformations. And monitor optionals, like we give 24-inch, 32-inch, 27-inch based on the requirement. So these are all the basic features we offer for a neuro and spine, where the mandatory features required for our applications with the competitive price and high performance and accuracy. So thank you for your time, and thank you for Dr. John for the special offer and opportunity for me to present our product. Thank you very much, and thank you, Dr. Magago, sir.
Thank you, Ram. Thank you, Ram. This is a new feature, and again, to disclose, we don't approve it or disapprove it. We just want to show it and give Ram a chance to answer any questions that any panelists may have. So we'll open the floor to anyone that has a comment or question. How are you doing, Harshad?
Hi, John. I'm fine.
Do you have any comments or questions for Ram on his operative microscope or any other of his products? Oop, I lost Harshad there. Yeah, this is new, Ram. I don't expect a lot of people to have feedback. Do you have any comments, Juma, at all?
Oh,
Okay.
no comment, but I think it's a good tool to use it. I think I would love to see it. I would love to attend any workshop that is going on in Africa or in India. I mean, if I can get that chance, I would really love to attend one of the workshops to see how it works. But I'm impressed. I'm impressed, really.
The workshops, they're very attractive to you, right, Ram? They're the best places to interact with neurosurgeons, workshops.
Yeah, yes.
They're useful. Are you planning to go
Yes,
to
yes.
Africa at all in the near future at all? You must do a lot of traveling, right, Ram?
Yes, yeah.
Will you be going to Africa in the near future? Do you know?
Very much awaiting, very much eagerly awaiting for the opportunity.
Okay, maybe we can set something up and together with a conference. We could join the two, because as you know, there's a huge demand, not a huge, but demand for operative microscopes, and certainly price is a big determiner if they're interested. So we appreciate you coming out. And you know what we could do, Ram, since this is a new platform for advertisers, I would like to televise from a booth when you go to these shows, is basically just with a smartphone, have a show. When things get slow on the floor, just say, okay, I'm going to talk. You talk to people that have presented that may welcome the opportunity to tell people on the smartphone that, yeah, I just presented, da, da, da. Do you know what I mean, Ram?
I understand. I can follow you. I can understand this things.
Yeah, we could try that if you want. Whenever you're on the floor, you could say, Dr. Bennett, can we do a live feed now? And I'll just,
Yeah.
anytime you feel that it might be advantageous for you to present your product so that people understand it, just give me a buzz and thing and say, Dr. Bennett, can we go online now from my booth? And some neurosurgeons may be attracted because they just want to, they don't care about your product. They just want to get on the camera and talk, which I
Yes.
know most neurosurgeons, they
True,
never
true.
met a camera they did not like.
True.
Okay, thank you
Okay.
very much, Juma. We're all set, and we'll talk to you about our future plans. And thank
Sure.
you,
Thank
Ram, for your
Thank
time.
you. Thank you.
Bye-bye.
you,
Bye
Dr.
bye.
John.
Bye bye. Bye.